Good evening, everyone, and thank you for joining us. My name is Carver. I'm a product specialist here at Oculus, and welcome to tonight's clinical webcast, How to Start a Dry Eye Center of Excellence. You have a text box on your GoToWebinar screen where you can enter in questions. Enter your questions at any time, and we'll discuss them at the end of tonight's webinar. Our speaker tonight is Dr. Marguerite McDonald. Dr. McDonald is a clinical professor of ophthalmology at both NYU, New York University, and Tulane University. She is a cornea/cataract surgeon with the Ophthalmic Consultants of Long Island, OSLI, in Oceanside, New York, and after years of research in 1998, Dr. McDonald performed the world's first laser vision correction procedure on a sighted patient. She was the first female president of both ASCRS and ISRS, the International Society of Refractive Surgery. And Dr. McDonald is very accomplished in research with over 1,800 publications. Dr. McDonald, I'm looking forward to your talk. Take it away.
Thank you, Carver, and thank you all for giving me part of your evening to talk about how to start a dry eye clinic of excellence. You know, I often say that if every optometrist and ophthalmologist in North America opened a dry eye center of excellence, we would be underserving the population. That's how much dry eye there is. So here are my financial disclosures, and we'll get started. So the best thing you can do, this is very granular here, starting at the beginning, is find a dry eye center of excellence that's about 50 to 75 miles away from you. Why? This is far enough away that if you come for a visit, a half-day visit with your practice manager and chief tech, they won't be threatened. You're just too far away. But it's close enough that you won't need to incur the cost of airfare and meals, maybe one stop on the interstate at the Cracker Barrel. That's about it. So be considerate. This, especially now during COVID, you can assure them that you will show up with double masks and a plastic shield, and you'll wear gloves. But definitely, if they allow you to come, be very considerate, because having visitors will slow down your colleague very significantly for the half day you're with him or her, and will rob him or her of any chance to answer emails, talk to her or text their spouse, take care of any personal business between patients. So ask in advance if you can order lunch for the office from their favorite restaurant or deli, and you can stay and chat with them during lunch or choose to drive away, but let them know in advance you're going to do that. So the doctor should observe their colleague while the chief tech goes along with their chief tech, and while your office manager gets as much info as possible regarding billing. By the way, wear scrubs or a lab coat so that you will blend in with everyone. That also is very appropriate for COVID, that you're wearing something that can be washed at the end of the day. And be sensitive about financial information. Some practices will share it freely and some won't. So just shadow the techs, the coordinator. Everybody should carry a notebook or take notes on a tablet or smartphone, and afterward send a gift with a note. But this is invaluable. You will absorb so much in half a day. It's worth 12 hours in a classroom. Then when you get home, start with a team meeting. You have to let the staff know this is important to you. They're not mind readers. You have to spell it out, and it's important for the benefit of your patients and for the health of the practice. So you have to get very concrete here. You know, you can say, I hope to continue to give everybody, raises and bonuses as appropriate, and this will help me. So, technicians will respond to this in a variety of ways. Most will probably be very proud that the practice is staying cutting edge, etc. But you have to convince the folks that see it as just more work that it is absolutely worth it for the health of the practice and eventually for their bottom line as well. So start marketing with incredibly inexpensive but highly effective tools. These things that I list here are very, very old school, and they work. The staff wears buttons on their uniforms that say, ask me about dry eye. Or, if you're sending out invoices, through snail mail, stick in a sheet announcing the Dry Eye Center of Excellence with the invoices and posters on the walls of the exam lanes, the dilating area, the lobby. We know that when the patients have finished checking their email, their texts, they start reading everything. And the poster on the back of the exam doors are largely closed now due to HIPAA regulations. You don't want people listening to what's going on with other patients. So they read what's on the back of the door, all low tech and highly effective. But you don't have to stay low tech. Rely on industry. The vendors are all very eager for our success. Our success is their success. They have all sorts of implementation teams and tools. They can link you to their website so patients on your website can see what you offer. They have trifold brochures. They have press releases. You don't have to reinvent the wheel. They've done it all for us. Once again, our success is their success. So to just put your toe in the water, I would recommend 3 things first that are very low cost and give you a ton of information. So not only are they inexpensive, but you won't be fighting with your partners. In most practices, there is one person who's really dying to start a Dry Eye Center of Excellence, and they have to convince the others. So if you start off with a low capital investment, that makes everybody happy, and it also gives you a ton of information. So a positive questionnaire, if the patient comes in and checks off even one symptom on the speed questionnaire, which takes 30 seconds to fill out, that allows the tech to proceed with ocular surface disease testing, such as tear osmolarity testing, before the patient sees the doctor. So that saves a ton of time. Now, why can't you just do testing on everybody? Well, that would be like saying, today we're doing fluorescein angiograms on everybody. You can't. But unless they're an established dry eye patient, in which case you can go right ahead, you have to establish that they had a symptom that triggered the OSD testing. So it's done before you see them. Hyperosmolarity is the central core mechanism by which dry eye damages the ocular surface, so it gives you a lot of information. And MMP9 testing, the inflammatory test, is the first and only rapid CLIA-waived in-office test that detects MMP9, which is a biomarker for inflammation, and it's consistently elevated in the tears of dry eye patients. So you get a ton of information with these very inexpensive tests. So once again, osmolarity is totally objective. Remember, half of people with significant dry eye have little or no symptoms. So when you see someone with a very dry eye and you tell them they have a dry eye and they say, no, I don't. You say, well, your tear osmolarity test is so high, almost make the machine go tilt. A normal score is 290 to 295. The machine goes tilt at 400, you're at 396. So the numbers impress people. It gets their attention. It aids in the diagnosis, of course, but also tracking response to treatment. And as I said, it's easy to implement. It takes less than 60 seconds to get tear osmolarity on both eyes. The tech does it. And it's a really relatively small capital investment. So MMP9 testing, the conj is dabbed with a little sponge, which is snapped into a cassette. That takes 10 minutes to perk. So that can be done while the tech is finishing the workup. So what exactly is MMP9 testing? The MMPs are proteolytic enzymes that are produced by stressed epithelial cells on the ocular surface, and identifying someone with an elevated score helps guide therapeutic decision-making. You know, if they have an elevated MMP9 score, they're going to respond to anti-inflammatory therapy, and it's also a small capital investment. You just buy a few at a time. So this just shows the positive test result on the left is comprised of a blue line, which indicates that enough tear was sucked up into the sponge. Whoop. And the red line means that it's positive. In other words, that it's greater than 40 nanograms per mil, because the literature shows that normals have a level of MMP9 that's 3 to about 41. So this shows us, and by the way, even though the Chair Lab people are going to quantify it soon, The speed with which the line turns pink and the deepness of the pink color tells you a lot as well. On the right is a negative test result. The blue line shows that enough tear was sucked up into the cassette, but the test is negative. So now you've got your toe in the water. Everybody's comfortable. Everybody's happy. We're a dry eye center of excellence. Now it is time to acquire Meibography. I cannot tell you how important this is. So a picture is truly worth 1,000 words. You can tell people they have Meibomian gland disease. You can tell people that's why they have horrible burning, this and that. And they say, yeah, till they see a picture. I've had patients actually scream when they see a picture of their glands. So it's helpful for us as doctors for grading and decision making, but it's super helpful to the patient for understanding their disease. It aids in compliance. It scares them into compliance. And it's the single most important thing that will motivate them to pursue an out-of-pocket in-office treatment. We're going to talk about that later. We're not there yet. We're still just getting comfortable with diagnostics. There is no better Meibography unit than the Oculus Keratograph 5M. It is the workhorse in any dry eye center of excellence. It has a top-notch placido topographer and numerous ways to measure the tear film, which I will show you. There's another shot of the unit. It doesn't have a large footprint in the office. So these are all the things this one device can do for you. For dry eye assessment, it analyzes tear film quality and quantity. The Meibography, as you'll see in a moment, is superb. Bulbar hyperemia is graded. Lid imaging, fluorescein imaging. The placido-based topography can be used by everybody in the practice to diagnose keratoconus and a host of other things. Corneal disease is detected. It's used for contact lens fitting and so much more. It is the workhorse. It has 4 illumination systems depending on the task at hand. And you see, depending on whether or not you're using it as a placido topographer far left, or you're using it for Meibography imaging, or looking for fluorescein staining, or whether you're using it for tear film dynamics on the far right, there is an illumination system that will automatically click in depending on the task at hand. And 3 levels of magnification. So once again, depending on what you're trying to do, your field of view will be either 10 millimeters, 15 millimeters, or 26 millimeters. Now, let me give you some examples of what it can do by way of ocular surface assessment, and very quickly. Non-invasive tear meniscus height, as you see here. This is a fairly low tear meniscus height. Tear film, so that's quantity. This is tear film quality. There's non-invasive keratometric breakup time, far left, tear film dynamics in the middle, and assessment of the lipid layer on the far right. So let me give you examples. The non-invasive keratometric breakup time, otherwise known as NICBUT, is incredibly useful. I love this just about as much as Meibography. It has such an impact on the patient. So here's a really dry eye. It's so dry that most of the placido reflections are so disturbed that there's just dropout. That's all the white that you see. So this color-coded map is not steepness of the cornea. This has to do with the breakup time in seconds. You're supposed to be down here in green, but this patient has a severe dry eye with a breakup time somewhere between 7 seconds and 3.5. So here you see the severe dry eye patient on the far left. After a few weeks of treatment in the middle, now there's no dropout. The whole area is digitized, is tracked and digitized. And the green color indicates that the tear breakup time is excellent. It's over 25 seconds, up to 30. And here on the far right, this eye has been successfully treated. It has a completely normal tear breakup time of basically half a minute. And there's the graphic plot representation of those values down below. This is impactful. You show this to a patient and they're stunned and much more likely to be compliant. So the lipid layer, we know that the colors of the lipid layer tell us a great deal about how thick it is. If you have a thin lipid layer, less than 60 nanometers, the colors are white. If it's moderate, you see mostly yellow. And if it's a nice thick layer, you see blue and all the other colors. So here's an example. This is a thick lipid layer on a healthy eye without dry eye. All the colors of the spectrum are visible. You see blue, bronze, yellow, brown, all of them are there. Here's another normal eye. You see bronze, yellow, brown, and some blue tones. But here is a thin lipid layer. It's white, virtually no colors, and there's a lack of structure to it. You don't see all the beautiful swirling patterns. Now, tear film dynamics, this is really amazing. So here you see there are little bits of debris in the tear film. So between blinks, the speed and direction of these little bits of debris are tracked. And that gives you invaluable information about the viscosity of the tear film. Amazing. So this can be captured for your tear report, the crystal tear report, which we'll talk about in a minute. Now, assessment of conjunctival redness, the R scan. Some doctors will look at this eye and say, well, that's 2+ conjunctival. Some will say 3+, some will say 1+. But you don't have to worry about inter-observer differences when you have an automatic grading. So you can analyze the whole conj as you see top right, or bottom right. You can isolate just the limbus. You can track ciliary flush in cases with iritis and uveitis. So this shows the categories. Grade 0, no findings at all. Grade 1, very, very mild injection, which is a standard value for an adult, especially in an urban area with all the trash in the air. 2, mild. 3, getting worse. And 4, severe diffuse injections. No one has grade 0 except young children and cadavers. Virtually everybody is grade 1 if they have a healthy eye and they're an adult. But this is all automated for you. Meibography. But like I said, I treasure all of these things, but this is my super favorite because it's so impactful for me in my decision making and to the patients. So the Meibography is classified for you. And here you see far left a really healthy eye. This is the tarsal surface of the upper lid, and you see long, healthy-looking Meibomian glands, very little curling. Then you see grade 1, grade 2, and far right, grade 3. So, you looked for the dropout, of course, but also duct dilation, gland constipation, curling, shortening. This is such a powerful tool to motivate patients to accept or perform preventive care. Every office exam lane has a picture of healthy eyes, intermediate MGD, and severe MGD. So I pull up their images on the screen in every exam lane, and I say, here's what your lids look like. Here's what they should look like. They should look like this top, it's a card, a laminated card. They should look like this top image. That's normal. You look more like the intermediate or the severe, depending on the case, image, and their jaws drop. So they understand they have a significant problem. Lissamine green imaging can be captured. We know that lissamine green is taken up, I should say, by cells that are in trouble, distressed epithelial cells. That can all be captured. Fluorescein imaging is beautifully captured, and you can see it in great detail. It is graded. You can look at tear breakup assessment, partial blink assessment. You can image the lids and the lashes. If you look to the far left, you'll notice, if you stare for a second or two, there are a lot of collarettes. And this patient has Demodex. On the right, you can express the Meibomian glands and capture an image of the quality of the altered meibum that is coming out. Is it clear? Is it starting to become opaque? Is it cheesy, like cottage cheese? All that can be captured. Let me mention in passing that it also does a beautiful job of pupillometry, which is important for cataract and LASIK surgeons to capture mesopic pupil size and document that. So all of this can be put in the crystal tear report. So it can be customized to your liking. It captures the items that you're interested in, makes an assessment, and spits out for you your treatment plan, which all has been customized in advance. So the keratograph images are captured by the technician. The patient's put in the exam lane. The doctor comes in, explains the results, does a slit lamp exam, and hands the patient the crystal tear report, which is printed out for the patient. And they are super impressed by this. Your practice logo is there. There are intuitive grading scales, the description of the tests that were done, and the treatment plan. So you can use the crystal tear report, or you can just fixate on one or two tests, but all is available to you through the Keratograph 5M. So now you are truly an expert in diagnostics. And after everybody is comfortable with diagnostics, it's time to add in-office therapeutics. So I would start once again, toe in the water, with professional lid cleaning with swab sticks. OcuSoft sells these. They are either impregnated with a to-the-trade-only eyelid cleanser or eyelid cleanser with tea tree oil if you have a Demodex patient. So you can have the patient sign an ABN, and they're paying for this out of pocket, and that makes everybody comfortable. So now you're starting to do in-office therapeutics. Pretty quickly, though, most people move on to Microblepharoexfoliation. This is the BlephX unit. Virtually every dry eye center of excellence gets into Microblepharoexfoliation. So you have a high-speed rotating sponge at 2,500 RPM. It doesn't hurt. It's soaked in, once again, in a professional eyelid cleaner. And you remove a lifetime's worth of biofilm stuck to the lid margin. Techs can do it. If you train the techs and the patients expect the tech to do it, there's no issue. Some doctors prefer to do it themselves, but it only takes probably about 4.5 to 5 minutes to do microblepharoexfoliation on all 4 lids. We've done about 40,000 of these in our very big practice, which spreads over 3 states. Owned by private equities. We're part of a huge organization, and not one person has ever said, please stop. It feels good, and you open up all those Meibomian gland orifices. We often pair, almost always pair, microblepharoexfoliation with some sort of thermal treatment. So once you've opened all these orifices, you want to get the altered meibum, the nasty goo, out of those glands. So this shows a lipoflow treatment. And we have this in several of our offices. IPL is another wonderful treatment, and intense pulse light from Luminous. This is the light-based heat and compression under direct visualization known as iLux from Alcon. And except, I think, doctors really should perform the IPL, but virtually everything else can be done by a well-trained technician. And it's all about setting expectations. If they expect the tech will do it, then there's no issue. This is tear care. This is another in-office heat treatment of the Meibomian glands, and it has the huge advantage of having the patient keep their eyes open. So while they're getting this treatment, they're looking at their iPhone, they're doing what they need to do. So you don't even have to have a tech in the room with them. You put these on and you leave, and the tech leaves. You keep the door open in case they want to call for someone, but the treatment takes a few minutes and the patients are happy because they don't feel claustrophobic. right after this, the doctor does rush back in and do a little lid expression. So now you are truly off to the races, and you can add additional technologies as needed. You don't need all those thermal techniques. It's just that, you know, we have over 40 offices, so each office has a different one, and we get to try them all and weigh in on how we feel about them, but they all work, and there's plenty of scientific evidence to document that they work. So pick and choose which additional technologies you want to add. Remember that the longer your doors are open, increasingly you will find extremely dry eye patients seeking you out. They will come from far away. So you have to be prepared to see shockingly dry eye patients. You need to stock lots of plugs and amniotic membranes. Pretty soon you'll have to find a source for serum tears, and you'll have to be familiar with nerve growth factor. I'm going to go over these. You should investigate scleral lenses for severe OSD, and you might want to get into the at-home treatments. So we'll just review those very quickly. Amniotic membranes. There are several companies. This is the ProCara Slim. It's an amniotic membrane from the delivery of healthy young women, birth products that would normally be thrown away. Nothing controversial here, no stem cell research. And these amniotic membranes are completely chock full of growth factors, most of which we haven't even identified yet. And the highly purified amniotic membranes, and by the way, the women are screened for AIDS, herpes, cancer, COVID, hepatitis, everything you can possibly imagine. But they're processed such that they are extremely clean and suspended on this little PMMA annulus. I find that 5% of the patients can't tolerate it, 95% can. They can feel that it's there, but it's not painful. But 5% find that it's intolerable. So after I put this in, usually they have a little proparacaine on board. I make them wait at least 20 minutes to make sure they're not in the 5% that has to have this immediately removed. So I have started about 6 months ago to use something called Regenerize. Regenerize is highly purified extract from, screened young women, healthy young mothers, extract of placenta and umbilical cord. Once again, chock full of wonderful growth factors. It is expensive. Patients don't always need to be on it for that long, but Regenerize is easy to order while the patient is sitting in the exam lane. You just type in their name, their cell phone, and their email address, and they contact them, etc. So I've begun to use a little more Regenerize and fewer amniotic membranes and fewer tears. So why did I mention oxervate? It is an agent, a biologic for neurotrophic keratitis. Well, that's because a high percentage of people with severe dry eye also have neurotrophic keratitis. Their corneal nerves are dead. So this is a biologic, and it's taken 6 times a day for 8 weeks, and it can be quite amazing in severe dry eye. So there are other things that cause NK besides dry eye, quite a long list, but you'll see people marching in who have completely dead nerves. The feedback loop has been so destroyed that they need oxervate. Now, scleral lenses, you wonder, why am I mentioning scleral lenses? Just a quick definition, it's a rigid gas permeable lens that's huge. It's large enough to make contact only with the sclera. It completely vaults over the cornea. So we know it's been traditionally used for irregular corneas, keratoconus, postcorneal transplant, ectasia, etc. But the newer applications are for almost normal eyes. So these are people, say, who are having trouble with their soft toric lenses. They never stay put. The axis keeps swinging. They have fluctuating vision. It's also used for high refractive errors, presbyopia, allergies, also stability for athletics or work environments, and dry eyes, ocular surface disease. So In the old days, you had to take one of your team members, an OD or an MD, and send them off to scleral lens school for weeks. And then they would come back and buy a giant set of diagnostic trial lenses. And it would be trial and error in the office, very time consuming and somewhat stressful for everyone. A custom mold of the eye shape is often required. And there would be fitting, and then fitting number 2, and then number 3. The sessions would go on and on. All that is gone now because of the Oculus Pentacam corneal scleral profile. So we know the standard Pentacam covers 12 millimeters. With the new software, it covers 18 millimeters. And literally, you have the patient look straight ahead, take a snap. You take another scan while they look up, down, left, right. So you have 5 scans. This is sent through external software. You send it into the Wave software. It's sent to the company with the patient's refraction. That's it. So I try everything. I also have dry eyes. I try everything. And we have a master scleral lens fitter in our practice, Dr. Jerry Diversa Jr. So I ordered my lenses. They came. Jerry had nothing to do with their fitting. It was done empirically. It was just me and a technician. I popped them in and he looked at me and his jaw dropped. He said, "These fit perfectly. I cannot imagine changing them in any way, shape, or form. They fit you perfectly." So this has changed the game for sclerals. And of course, the advantage for dry eye is that they bathe the eye all day with fluid and they don't even touch the cornea. So if you have a dry eye center of excellence and you've been open for a little while, you're going to want to get into fitting sclerals, but especially with the Pentacam Wave software, because it does not require any skill at all, virtually none, and so helpful for dry eyes. So a lot of doctors get into at-home care. So in between their office procedures, the patients are doing something at home more than just lid scrubs with a wipe. This is New Lids out of Hawaii, NULIDS, and basically it's an at-home Microblepharoexfoliation unit. And they pop in a new little disc every day, and they cannot hurt themselves. You cannot give yourself an abrasion with this. The tips are very soft little polymer fingers, and a lot of patients just love this. They're addicted to it. So that's an at-home device. New therapeutics. Here's the eye tier 100 for Olympic ophthalmics being demonstrated by my dear friend, Dr. Laura Perriman, who's a dry eye expert. So she's holding this thing up against the outside of her nose because there's a branch, the trigeminal nerve, on the inside of the nose, right there, sort of halfway up, halfway between the tip of your nose and where the bridge of your glasses would sit. So if you give a little external stimulation, that shoots up the trigeminal nerve and causes the lacrimal gland to produce tears. This is about $150. You have to send in a script, and there are a lot of papers in the peer-reviewed literature documenting that it works. And it has the advantage of being $150 as opposed to $1,000. Allergan did have True Tear, which required putting a prong device up the nose, and it did work, and desperate dry eye patients loved it, but it was extremely expensive. The base unit was not covered by anyone's insurance, and it was sort of like giving yourself a COVID test several times a day. You had to stick that pretty far up your nose. So if you were at a dinner party and you pulled out this little device, you might raise an eyebrow, but nobody would be upset or disgusted, whereas if you put this huge prong up your nose in the middle of a dinner party, it would be very upsetting. So I think cost and patients' distaste of shoving something up their nose probably did in True Tear. It's no longer available, but it did teach us a whole lot about the trigeminal nerve, how to stimulate it, and its role in treating dry eye. So I'm really sorry it's gone. So here's a tip. Stay in touch with that colleague that you first visited. You might want to plan the occasional return trip. Every once in a while, every year or two, you might want to swing by for half a day. Remember, get up early, be nice, get there. You won't incur much expense. Take your office manager and your chief tech if you are allowed to. And remember, it's just one little stop at the Cracker Barrel on the way home. So it's an inexpensive trip. So in conclusion, it's good medicine to treat dry eye. We have so many better diagnostic technologies, especially the 5M, and treatments, which lead to happier patients and better surgical outcomes. There's very low medical legal risk, virtually none. I'm knocking on wood here, don't know of any dry eye related lawsuits. The visits and the in-office treatments will greatly enhance your bottom line. That was not the focus of this presentation. I'm working on another one that details exactly a chapter and verse how it can enhance your bottom line. And the comorbidities will also enhance your bottom line because older patients get dry eye, but they also get cataracts. Thank you so much.
Great. Thank you so much for that wonderful presentation. Just to remind everyone, there will be a recording of the presentation that will be sent out after the webinar tonight. Another reminder, now is a perfect time to enter in questions into the chat. If you have anything that you're dying to know that wasn't already addressed, now is the time. And we're going to go ahead and get started with the questions. All right. So the first one is fairly simple. Do you have the text apply fluorescein for testing? I'm going to assume that you do. Most practices have the text to it.
I do not have the tech put in fluorescein. I have them take the pressure, usually with non-contact, unless they're a glaucoma patient or a glaucoma suspect. I put in liquid fluoresce. I like the liquid version of fluorescein. Some people like the strip. I put it in myself when I'm in the room with the patient.
Great.
And very quickly, the reason I do that is that if the fluorescein sits in there for a few minutes, it just smears everywhere and you can't see any detail.
That makes perfect sense. All right. So I have a doctor that's kind of seen a number of cases where, let me know if this is a little bit too specific of a question in terms of getting too close to giving medical advice for an actual patient. But in terms of patients where the Meibomian glands appear normal, but there appears to be no lipids in the lipid layer, what further testing would you kind of recommend in terms of those cases?
Meibography, it could be that they are clogged, that are completely occluded. So Meibography would give you a tremendous amount of information.
Great. Next, I have a question about the true tear treatment that you talked about, and kind of asking about, are there other devices similar to it on the market? I believe the one mentioned here is EI by Swin. Are you familiar with other devices like it on the market?
I'm just clicking through my slides again. Can you still see my slides?
Yes, perfect.
Okay, so the iTear 100 from Olympic Ophthalmics does this sort of stimulation, but through the external skin, not through the nose. And, like I mentioned a few minutes ago, TruTear worked. It was just that it was very expensive. And, we compare it to the insulin pump. If the base unit were not covered by insurance, the insulin pump would have died in the marketplace. And unfortunately, the base unit for TruTear was not, but it surely did work. And it was for desperate patients, they would have stuck it up their nose. They would have gone to the ladies' room if they were at a party and they would have used it there. And I say ladies' room because most severe dry eye patients are female. But it worked. And there are several devices that are now being offered that do provide electrical stimulus externally. Now, the man who invented TruTear and sold it to Allergan. Michael Ackerman, a brilliant scientist. He is now with Oyster Point, and they're hoping to get FDA approval for a nasal spray that will stimulate the trigeminal nerve without having to put a prong up the nose. So if that gets FDA approval, it will probably be sometime during 2021.
Gotcha. That definitely sounds like a much more appealing treatment for a lot of people.
Yes.
All right. In terms of the, topical drops, do you have a favorite brand?
Of artificial tear?
Yes.
I give my patients a big sheet that has all the over-the-counter products for dry eye. It's a huge sheet. And it's all color images. And I circle, most of my patients need preservative-free tears. I have to switch in my treatment scheme, which is based on peer-reviewed science. Only the mildest of patients can use preserved tears. So, excuse me, but they're all on the sheet. So I circle the whole group of preservative-free, and I say, you will find a favorite in here. You can experiment with different brands. As long as they're preservative-free, I'm happy that they're using it. I do mention that Refresh Soluvisc is super heavy. It's very, very soothing, but it might be used in the evening, or, don't put it in at a stoplight and hope to see when the light turns green. The rest are medium to low viscosity, and you could actually do that. In one blink, you could see, but not with Refresh Soluvisc, which I like very much, especially for severe dry eye. But I do give that one warning. But I tell them, just try one of these. And if I have samples, of course, we all have fewer samples thanks to COVID because the reps don't want to come in or can't or are not allowed to come in. But at least they find it easier to shop because they have that picture and they can go to Rite Aid or Walgreens or whatever and shop with it.
Great. Thank you so much for that answer. I have a few questions about amniotic membranes, kind of centered around how you decide when to use it, both in terms of dry eye and in terms of, do you ever use it with post-LASIK patients?
So I often use it when there is a patient with a chronic epithelial defect that's not healing. I will freshen, due to severe dryness, I will freshen up the edges. Usually there's a kind of a gray elevated edge to the epithelial defect. I'll get rid of that and pop on the amniotic membrane, and it's amazing how quickly it heals. Also, if someone is having just a severe exacerbation of dry eye, like disabling, like can't go to work, they'll pop on the first eye. In some cases, I've put them on both eyes at the same time, but they're gray, and until they start to melt, that really knocks your vision down. If you're capable of, say, 20/20, which few of them are because they have so much SPK, but if they're capable of 20/20, it'll knock you down to 20/70 or 2100. So it's very hard to put it on both eyes on the same day, but I've done it for extremely severe cases. But you cannot imagine how many great cytokines there are in there, growth factors, and there are many more we haven't even identified yet.
Great. All right, I have a question about scleral lenses and MMP9 and a short-term buildup of MMP9 as a result of scleral-like lens use. Do you ever find that to be like a complication? And if so, how do you kind of address that?
Well, usually people who are on a scleral lens for dry eye, they have pretty severe dry eye, and they're on one of the 3 RX medications for long-term control. So that's Xiidra, Restasis, or Cequa. So those are so powerful as anti-inflammatory agents that they don't get a big buildup of MMP9 inside the scleral lens, not at all.
Great. That's actually a fantastic answer. I have another question asking if you have a favorite between those three brands.
Well, they all work very well. And now it's really about their insurance. So, Medicare patients have to be on this one, and Medicaid have to be on that one, and the commercial plans. The commercial plans, of course, give you much more freedom. And with a commercial plan and a coupon, you can get people on Xiidra or Cequa, and the cost is very reasonable. And those both kick in faster than Restasis. So if the insurance plan calls for Restasis, that's fine. It is a great medication, very safe. It'll just take a little longer to kick in. But I use all three all the time, every day, depending on the patient's insurance.
Great. All right, I have one more question about the amniotic membrane, which is basically how long do you treat patients with the amniotic membranes for?
I leave them on for 5 to 7 days. And honestly, if you can get them to wear it for 3 days, they dump most of their goodies onto the eye in the first 3 days. The more they need it, the faster it will melt. So if you see them coming back at 5 to 7 days and the ring is completely empty, it's sitting there just as a PMMA ring, and there is no membrane suspended across the center, that's because it was all melted away and that eyeball needed that membrane. I've had some people who need more than one membrane. This is rare. Usually it works very quickly and very well. And some people need a break. Some people say, I need 2 or 3 days without this. Even if it's not causing pain, and I mentioned that 5% of patients have to have it taken out immediately, they just need a break. It's sort of like it's like wearing a really tight belt. It's not painful, but you really don't want to do that for too long. They can feel that it's there. So I've had some people take a little weekend break, then we put another one in. So if there's substantial improvement in the epithelial defect or the heavy SPK and the filaments, okay, take a break. Next week we put in another one. So I've actually done serial amniotic membranes in some cases. Most people need just one, and that pushes them off their healing plateau, and that's really all they need.
Great. All right. I have one additional question about actually, I have 2 more questions about scleral lenses. One is just kind of a mechanical question about how they help with dry eye. And a second is, do you ever kind of use a full drops of a regenerative drop like Regenerize before doing a scleral lens insertion?
So they help dry eye because they vault over the cornea, don't touch the cornea, and they bathe the eye all day in whatever solution you put in the scleral lens. And there are recommended fillers that are basically buffered saline that work beautifully, but the eye is bathed in fluid all day. So that's how it treats the dry eye. And the second was, what was it, Carver? It was
the second was, do you ever use a few drops of Regenerize before putting on a scleral lens?
Well, once again, people wearing sclerals for dry eye are usually pretty dry, so they're taking one of their 3 long-term management prescription drops, Restasis, Cequa, or Xiidra. And yes, they can throw in a Regenerize drop before. You wouldn't put Regenerize, you wouldn't dump a lot on top of the scleral lens while it's in, because it won't get under, but when they take it off at night, yes, they would take their second drop of Regenerize and their second drop of one of those 3 prescription meds. And they could toss in another Regenerize or 2 before they go to bed.
Great. All right, I think we're coming up on the final few questions that we have time for tonight. If you have any burning questions that you need to get asked, go ahead and get those asked. I have a few favorites that seem to get asked very frequently, but it's an interesting question. Do you have a favorite omega-3 ratio in terms of the different omega-3 proteins?
I do, 3 to 1 EPA DHA. And so I have to say I'm very fond of the formula that PRN offers. It has that exact formula. It's been the one that has been tested the most, about which there are the most peer-reviewed papers, and it's re-esterified, so most of it is absorbed. The sad truth is that most omega-3s go out in the stool, but if they're re-esterified, they're highly absorbed.
Mm-hmm. Great.
So they make a product called DE3, Dry Eye 3. And
Awesome.
yeah, it is awesome. I take it, my husband, virtually every doctor in our practice takes it, and virtually every one of my dry eye patients take it.
Perfect. All right. I have a more kind of decision kind of tree question where there are so many treatments available for dry eye. And patients can really only take so many options. Like they can only be treated with so many things. How do you kind of narrow down in what's going to be most effective for your patients?
Well, I have a treatment scheme that I long ago memorized, but I grade their dry eye and their Meibomian gland disease very quickly. And so the treatment scheme is actually very similar to what ASCRS published, and almost virtually identical. So ASCRS came out with a clinical treatment guideline about 18 months, not even 18, about 14 months ago. And it's virtually identical to what TFOS came out with, the Tear Film and Ocular Surface Society. So once you read them, after doing this for 2 or 3 days, you don't have to refer to them. They're in your head. And so at the very bottom of the treatment scale, somebody with extremely mild dry eye that is only symptomatic once in a while under extreme environmental conditions, like being in a speeding motorboat for 7 hours on the 4th of July, and they're not behind the windshield. Somebody who stays up till 3 a.m. dancing at her sister's wedding with her contacts in, extreme environmental insults on rare occasion can be treated with gently preserved artificial tears. But then you get into the people who have chronic issues, and their time doesn't allow, but the ASCRS treatment algorithm and TFOS and the DEWS report, dry eye workshop, they're all identical because they're all based on the same peer-reviewed papers. So, in the beginning, I had them tacked up on the wall. And then very quickly you memorize them and you don't need to look at the wall anymore.
Makes perfect sense. You have a ton of experience in the field, and we are so grateful that we get to ask you all of all of these questions.
My pleasure.
Great. So I think this might be kind of the final question of the night, given that we're almost at the hour, depending. I was going to say 9 o'clock, but that depends upon the time zone. But patients, their dry eye is often affected by already having contact lenses in. Some patients wear glasses, but if they do wear contact lenses, do you have them come in wearing their contacts, or do you have them take their contacts out and just wear their glasses?
That's very interesting. So if they have their contacts in, then the tear osmolarity test cannot be performed. So I would prefer them to come in with glasses on. If there's an issue of, contact lenses, soft ones are so forgiving. You rarely see tight lens syndrome anymore or corneal hypoxia anymore. But if I begin to suspect that the contacts are actually causing some of the issue, I'll have them pop them back in. So I want them to come in with the contacts. I want them I want to see the box so I get the base curve diameter, all that information, but I want them to come in with their glasses, but ready to put the contacts in if I want them to.
Great. All right. Actually, it looks like we have time for one more question. I think that's a little bit of luck. All right. So I have a question on doxycycline for MGD, especially in patients with acne. Uh, do you like using doxycycline on those patients?
I love using doxycycline on those patients, and it'll clear up their lids, it'll clear up their skin. Now, I'm actually a minimalist, so for most people, a month of 50 milligrams PO once a day is enough. You do have to document that the patient says that she is not pregnant or planning to become, because if she takes it while she's pregnant, she'll have babies with little brown teeth, and she will have terrible dental bills. But and you also have to warn the patients not to take it within plus or minus 1 hour of a meal containing dairy, because dairy inactivates doxycycline. And lastly, you have to tell the patients that it will make them more sun sensitive. So wear a hat and shirt and sunblock when they're outside, SPF 100. Having said that, I often give people a month, but some people have to be on it for several months. And there are some very, very severe cases that just have to be on it for years, like the kids with teenage acne. And it's a very low dose at that level. It's sublethal for bacteria. It works its magic at that dose by being anti-inflammatory for the skin. It's one of the very few indications for long-term oral antibiotic use, but it's magical. It's a big, big part of the armamentarium.
Great. Thank you so much for your presentation and all of your expertise. If we were unable to answer your question tonight, as there are a lot of device comparison questions and stuff like that we just simply didn't have time for, I'm sorry about that. But you can go ahead and reach out to Dr. McDonald and maybe ask a few of those questions, and we'll hopefully be able to address some of these questions in a future presentation.
Thank you, Carver. It's been my pleasure, and I would be delighted to answer any questions that come my way. And my final thought is, don't be afraid to open a dry eye center of excellence. You'll find it incredibly gratifying.
Perfect. Have a good night, everyone. This concludes our presentation.